I just want to highlight again the regional anatomy of the pulmonary veins. The pulmonary venous antrum, the posterior wall, is what we often have called it, but the posterior wall is actually divided into two parts. You've got this part here, which is the vestibule, which is the vestibular portion, and then the portion that we're unable to see is this pericardial reflection that looks like an inverse U, and then this would be the dome portion of the posterior wall. So electrophysiologists will often say, well, I just did the posterior wall, and we'll box in between the veins. But what we don't always get is the vestibular regions here, which is really the strength of convergent. And I think that's why there's a couple variables of epi, endo, but also vestibule versus dome. The other important part is the coronary sinus is on the inferior portion of the vestibular region of it, and Dr. Fang is going to now come from the dome part where we've got the catheter up here, and that's our first row across. And then now we're going to pull back and probably do a second row across the vestibular portion. And the question is, how far do you go? Well, you want to obviously have a safety margin from the coronary sinus. The surgeons for the cryo will do an inferior mitral line that basically connects the coronary sinus to the inferior line between the veins. This is an area that we never do in radiofrequency ablation, but an area that Dr. Fang could also think about even hybridizing a hybrid procedure by doing cryo on top of that, because the fear here is circumflex artery or other coronary venous damage. So this is really important to show the differences, and what we're doing is stacking 1, 2, 3, 4, these rows, and then doing more rows down here. And that's really what's going to see, and then we'll obviously be able to see the portions on the endocardium to assess